to attend. Okay, so today we're going to talk about the anatomy of the liver and the biliary system. Okay, liver is a large organ. Have you seen it? Not yet. In the lab, you will see it's a huge organ. It comes to about 2 to 5% of your body weight. You know, it's more in newborns, younger children, and then as you grow up, other organs will be larger. So at least will come to about 2% of your body weight. It's a huge organ. You're going to see it. It's going to extend from the right hypochondrium all the way to the left hypochondrium, crossing the epigastric area. You know the abdominal regions, right? You know? No? Yes? Okay, so the right hypochondrium is the area here just below the costal margin, below the ribs. This is the below the xiphoid process, that is the epigastric area, where you find the stomach, and then this is the left hypochondrium on the left side. So the liver is a huge organ. It's pyramidal in shape. Base is here on the right, and it goes all the way to the left. Upper border reaches the level of the 5th intercostal space. You know what we mean by intercostal space? Space between the ribs, right? So this is the first rib, and then that is the second, that is the first intercostal space, and so on. So 5th intercostal space is between the 5th rib and the 6th rib. Okay, on the right side, it is a bit higher, right? So it is at the level of the 5th costal margin, basically the rib. You know, the rib has bony part and cartilaginous part. So we call that the, costal margin, costal cartilage. Now, why is this important? That you know that the level almost, the upper border of the liver goes up to the level of the nipples, clinically. Why do you think we have to remember this? Right, yeah, we have to remember that because, for example, in case of, trauma to the chest, we always think of trauma to the lungs and the pleura, right? But a rule of thumb, any injury below the level of the nipple, you have to consider injury to the liver as well, okay? So keep that in mind. And, on the right side, at the mid-axillary line, the liver extends between the 7th and the 11th rib. So it's a huge organ. The lower border here goes from the right to the left, or from the left to the right. It's, about a hand breadth from the xiphoid process. That's where you find the lower border of the liver. Now, liver has two surfaces. For us to be able to see this, we have to remove the diaphragm, right? Liver is underneath the diaphragm, right? Immediately. So for us to see this, you have to cut or remove or flip the diaphragm. So this is called the diaphragmatic surface. And the other surface is the inner surface, the surface inside that is in touch with the viscera, the organs, and we're going to call that the visceral surface. And the lower border here separates between the two. So this whole thing is the diaphragmatic surface, right? And it has different parts. This is the one on the right. It's called the right part of the diaphragmatic surface. This is the anterior, and this is the superior, just below the diaphragm. And we have another part of the anterior surface, which is the posterior surface. Now, the posterior surface is bare of peritoneum. It is naked. It's not covered by peritoneum. Why? Because this is the surface or part of the diaphragmatic surface where the liver is attached to the diaphragm. Okay, so if we were to remove, this is the diaphragm here, the liver used to be here. If we were to remove the liver, this is the impression that is left, This is where the posterior surface of the liver was located. It's called the Bile area here. This is the area of the attachment of the liver to the diaphragm, and it is devoid of peritoneum. And in that posterior surface, you have the inferior vena cava going through, passing very intimately, very close to the surface of the liver. So this is the visceral surface, the surface that is in touch with the viscera. So diaphragmatic surface has parts, right, anterior, superior, and then we have the posterior surface, which is the Bile area of the liver, and then we have the visceral surface that is in touch with the viscera. Now, if we lift the liver up, you can see the gallbladder and other structures that are in touch with the viscera, as we're going to see later on. Now, anatomically speaking, the liver is divided into large right lobe and smaller, tiny little left lobe. And the large right lobe has two smaller lobes inside that we're going to talk about later on. Now, the line of division is actually this. This is called the falciform ligament. It's a two-layer fold of peritoneum coming from the anterior abdominal wall towards the liver. So it goes from the anterior abdominal wall to the liver and starts wrapping the liver. Now, in the free border, lower free border of the falciform ligament here, we have what is called the round ligament of the liver, or the ligamentum teres. Where it's coming from? Now you have taken this, right? This is the fetal circulation. This is blood circulation of the baby inside the uterus. Okay, so this is the baby here, and this is the umbilicus, this is the umbilical cord, and that is the placenta, right? So the source of nutrients and gases and whatever to the baby is what? Is the placenta attached to the uterus of the mom, okay? And all the blood rich in oxygen and nutrients will be going through the umbilical cord to the baby. So what are the constituents? What do you find in the umbilical cord? You have the umbilical vein and two umbilical arteries. So umbilical vein will bring the nutrients and gases, oxygen to the baby, and the waste and CO2 will go through the umbilical arteries. Again, back to the umbilical cord, to the placenta, to the mother side, okay? Now, this is the umbilical vein. It goes inside. It's supposed to join the portal vein in the liver, because it should take, whatever blood into the liver if it needs processing. But as a matter of fact, blood is ready. No further processing needs to be done at the liver level. So most of the blood will be diverted into the inferior vena cava. Instead of going to the liver, most of the blood will be diverted to the inferior vena cava. This diversion, this little detour, is called ductus venosus. Okay? Now, what happens after delivery? The first thing you do after the baby comes out, what do? You clamp or you cut the umbilical cord. Done. We don't need it anymore. So what's going to happen to the umbilical vein and this detour, the ductus venosus? Okay, with time, it's going to be what? Obliterated and will be turned into a ligament. So now the umbilical vein becomes the ligamentum teres, or the round ligament of the liver, and the ductus venosus becomes ligamentum venosum. So both of them will become ligaments. So this is the obliterated umbilical vein, which is this. Now we call it the ligamentum teres, or the round ligament of the liver. And this ductus venosus again becomes a ligament, and we're going to call it ligamentum venosum on the visceral surface of the liver. Okay? So liver is divided by the line of attachment of the falciform ligament into large right lobe and smaller left lobe. And what do we find in the free lower border of the falciform ligament? We found a round ligament, or the ligamentum teres of the liver. You can see it here. It's going into this fissure and it's joining the portal vein in the liver. Okay. Now, this is the visceral surface. So you lift the liver up and you can see that is the visceral surface. It is in touch with the viscera. So if I let it go down, we'll be in touch with the esophagus, we'll be in touch with the stomach, with the duodenum, with the kidney, and on it you can see the gallbladder. All right, so this is the visceral surface. But let's have a better look on what do we find on the visceral surface. Now, this green structure is the gallbladder, right? And this blue structure is the inferior vena cava. Now here on the left side, you have the fissure for the ligamentum teres, or the round ligament, and you have fissure for the ligamentum venosum. And in the middle here, we have what we call the Porta Hepatis. Porta from port. It's where structures enter and leave the liver. Okay, so let's enlarge it. Here you have the inferior vena cava, you have the gallbladder, you have the ligamentum teres, and you have the ligamentum venosum. It's like an H shape. One arm is the inferior vena cava with the gallbladder. The second arm is the ligamentum teres with the ligamentum venosum. And the transverse, or the cross here, is the Porta Hepatis, the port where structures enter and leave the liver. And mainly, what do we see in the Porta Hepatis? You see the portal vein, hepatic artery, and the bile duct. Okay? And in order from deep to superficial, it is VAD, vein, artery, and duct. Okay? And of course, you will have nerves, you will have lymphatics, you will have lymph nodes, all the structures entering and leaving the liver. This is called the Porta Hepatis. Now, these three structures, the Porta Hepatis, the VAD, the portal vein, the hepatic artery, and the bile duct, they are all included in this ligament. It's called the Hepato-Duodenal ligament. Between the liver and the lesser curvature of the stomach, we have a two-layer fold of peritoneum. We call that the lesser omentum, right? Now, this part of the lesser omentum between the duodenum and the liver is called the Hepato-Duodenal ligament. And if I open this Hepato-Duodenal ligament, you're going to see these three structures in the portal triad, or the Porta Hepatis. So the portal vein, hepatic artery, and the bile duct. Okay, so this is the H shape on the visceral surface. This is the inferior vena cava, gallbladder, and this is the ligamentum teres and ligamentum venosum. And the cross here, or the horizontal arm, is the Porta Hepatis with these three structures. Now, on the large right lobe of the liver, we have two tiny little lobes. We call them, one of them is the caudate, between the two veins here. And the other one is the quadrate lobe of the liver, between the gallbladder and the ligamentum teres. So quadrate and caudate, they are part of the larger right lobe of the liver. Now, this is the visceral surface. Again, for you to be able to see it, you have to lift the liver up. If I let it go, it will be in touch with the esophagus, will be in touch with the stomach, with the duodenum, with the kidney, and with time, and probably they're going to stress on that in the lab, you're going to see it, they're going to leave an impression. So the kidney is always in touch with the right lobe of the liver. So with time, it's going to leave like, a depression, like a little cavity. That's we're going to call it the renal impression. And similarly, the esophagus will have its own impression. The stomach will have its impression on the, like this. So the esophagus will be here. That is the esophageal impression. Stomach will be here, right? If I let this go down, and this is the gastric impression. Duodenum, as we're going to learn later on, will be in touch with the gallbladder and so on. This is the kidney, where the kidney is located. It's better to see this, and this is the colic impression, where the transverse colon is located, right? So you're going to discuss this in the lab, but we call them impression. Basically, over time, you know, the contact between the liver and the viscera will leave impressions, right? Will leave traces. Now, so peritoneum will cover the liver completely, as if the liver gonna wear the peritoneum, right? Except the bare area where the liver is attached to the diaphragm, because peritoneum is gonna wrap the liver and then it's gonna face the diaphragm where the liver is attached. So it's gonna cover the diaphragm later on. Okay, so liver is completely wrapped by the peritoneum, except where the gallbladder is, because between the gallbladder and the liver, we don't have peritoneum. Actually, the peritoneum covers both the liver and the gallbladder. And of course, where we have these structures, Porta Hepatis and the two fissures, are not covered by peritoneum. Otherwise, the whole liver is covered by peritoneum, so except Porta Hepatis, except the area of the two ligaments and the bare area that we call it the posterior surface of the liver. Now, you know by now, we'll discuss anatomically later on, the portal vein. Portal vein is found behind the neck of the pancreas by two veins, splenic, superior mesenteric. But there are other veins that will drain into the portal vein. Simply, portal vein is a system of veins that is designed to take the absorbed nutrients from the gastrointestinal system to the liver, which is the largest factory for further processing. So portal circulation is specific to the gastrointestinal system. So it's going to drain the spleen, pancreas, and the gut, the intestine. Okay? So portal vein, 70% of the blood going to the liver will be coming from the portal vein. Portal vein will come, will divide into right and left, and then it keeps dividing into smaller. Finally, we'll have the blood going into what we call the sinusoids, like cavities. And then the liver is going to take whatever it needs, and the rest has to go back to the circulation, right? So what is the blood supply of the liver? It's portal circulation, 70%, but that is not enough. Why it is not enough? Yes, well, can I see you? Will I hear you better? Yes. Yes, that is the reason. Portal, it's a vein. So it carries non-oxygenated blood, deoxygenated blood, right? All veins carry non-oxygenated blood with the exception of pulmonary veins. All arteries will be carrying oxygenated blood except pulmonary arteries. So this blood coming from the GI to the liver is not enough because it is not oxygenated. So liver will die without oxygen. So it needs a source of oxygenated blood that will come from the hepatic artery. Okay, so portal vein will come, divides right and left. Each will divide further. Finally, sinusoids. Liver takes whatever it needs and it's going to send the waste and the rest of the blood back. You cannot afford to leave blood in the liver. Otherwise, it will become huge and you will lose your blood, right? So the blood has to go back to the circulation. So from the sinusoid, smaller veins, venules, bigger veins will be formed. And eventually you're going to have 2 or 3 hepatic veins that will join the inferior vena cava. So the blood that is not needed and the waste can go back to the circulation. Will you be able to see the hepatic veins? No, never. Why? Because the moment they are formed, they will enter into the inferior vena cava. And how far the inferior vena cava from the liver? It's very close to the liver on the posterior surface. So the moment they emerge, these 2 or 3 hepatic veins, they will enter into the inferior vena cava. So you will never be able to see the hepatic veins. Okay, so the liver is drained by hepatic veins, they will go into the inferior vena cava. Now, lymphatic drainage, of course, lymph nodes are located in the Porta Hepatis, and from there, they're going to follow the arteries, as we said earlier, along the hepatic artery to the celiac lymph nodes, which is the celiac trunk here, which is the origin of the hepatic artery. But also remember in the bare area, where it is attached to the diaphragm, the lymphatics actually go from there through the diaphragm, and they reach the lymph nodes in the mediastinum, in the thorax. That's why, in cases of liver cancer, you can find enlarged lymph nodes where? In the thoracic cavity, between the lungs, in the mediastinum. Okay? Because, as you know by now, one of the routes for the spread of cancer, where cancer cells move from the main or the primary tumor to other areas, which we call metastasis. How do they spread? Blood vessels, lymphatics, or locally start invading surrounding structures. Now, we said anatomically speaking, the liver is divided into large lobe, right? And the smaller left lobe. Anatomically speaking, by falciform ligament or attachment of, but physiologically speaking, the liver is divided into 2 equal halves. Why? Because it receives portal vein that's going to divide into right and left. The right goes to the right half of the liver, and the left goes to the left half of the liver. Similarly, the hepatic artery divides into right and left. The right goes to will supply the right half, and the left will supply the left half. Again, the bile will be collected by the left hepatic duct from the left half, and the right half will be drained into the right hepatic duct. So physiologically speaking, the liver is divided into 2 equal right and left halves, right? And if you read about it in anatomy textbook, liver is further divided into sectors. 4 sectors: left lateral, left medial, right anterior, right posterior. Not only that, but also it is divided further into 8 segments. Segments 1, 2, 3, 4, 5, 6, 7, 8. I don't want you guys to know this. I used to teach this previously, and will tell you, this is caudate lobe, is segment number 1, then you go anti-clockwise and so on. No need to know these segments and these sectors for all. But you need to know that the liver is divided into 8 segments simply. What is special about this or those 8 segments? Each segment has its own branch of the hepatic artery, has its own branch of the portal vein, has its own bile duct. What is the importance of this? Exactly. So as if they are 8 independent functional units. Each has its own independence when it comes to blood supply and portal circulation and drainage. So if a tumor is in this segment, you can remove it without affecting the functions of the rest of the liver, and so on. So liver is divided into right and left equal halves, and in generally speaking, divided into 4 sectors, and also further subdivided into 8 segments. Each segment has its own branch of hepatic artery, portal vein, and bile duct. No need to know these names, right medial, left medial, anterior, posterior, whatever, and no need to know these 8 segments, for me at least at this stage. Don't worry about that. It's enough that you know that the liver is divided into 8 functional or independent segments. Don't memorize them. Now, one of the functions of the liver is to produce bile. Why do we need bile? Yeah, emulsification of fat or digestion of lipids, fat, right? So liver is going to produce bile. So bile from the left half is going to come through the left hepatic duct. From the right half is going to come from the right hepatic duct. They unite, becomes a common hepatic duct. And then it changes its name, it becomes a common bile duct. Digestion of fat, it occurs where? In the small intestine. So you have to deliver the bile into the small intestine, right? So the common bile duct here is going to go to the second part of the duodenum, as we're going to see later on. It enters the posterior medial wall of the second half of the duodenum. Now here, there is a sphincter. It's called the sphincter of Oddi. Will not allow bile to go through whenever it wants, right? We have here cells, enteroendocrine cells that will sense. If you have fat in your small intestine, then sphincter will relax and bile will be allowed to go, because these enteroendocrine cells will secrete cholecystokinin, CCK, and secretin. CCK will go to the gallbladder to contract and will relax this sphincter. Now, you're always producing bile at a rate of 40 mils per hour. You produce 1 liter of bile every day. So what happens if you don't eat fat and this sphincter is closed? What's going to happen to the bile that is coming down all the time? So bile is going to come down, it's going to accumulate, oops, it's going to find this sphincter closed. What's going to happen? Bile is going to go back, as if you're filling a cup, right? So this duct will be filled with bile, and then bile will be going all the way through this duct. It's called cystic duct, to this structure, the gallbladder. So bile will be stored, water will be absorbed, bile will be concentrated in the gallbladder. So what is the function of the gallbladder? Production of bile, right? Right? Does not produce bile, it stores bile. So bile coming here, sphincter closed, will go up. There is a two-way duct, it's called the cystic duct, that is always open, will allow bile to go there. Now you eat McDonald's, you eat fatty meal, and then these cells will sense that there is fat. You need to digest it. So we'll relax, we'll secrete CCKs, cholecystokinin. That goes, we'll ask the gallbladder to contract, and the sphincter will relax, so the bile will go in. Okay? Now, this is we call that the extrabiliary apparatus. This is the right and the left hepatic ducts. They unite to form the common hepatic duct. And they are joined by the cystic duct from the gallbladder. Then it changes its name, becomes the common bile duct. Common bile duct opens into the second part of the duodenum. Now, this is the gallbladder on the visceral surface of the liver. This is the gallbladder. If we open it up, you can see the mucosa is like cavities, honeycomb appearance. This part is called the fundus. This is the body, and then you will have the neck. Sometimes, due to stone impactions, you might have a pouch. It's called the Hartmann's pouch. This is not normal. This is pathological. So fundus, body, neck, and then you will have the cystic duct. Now, the mucosa of the cystic duct is arranged as, spirally. And we call it that the spiral valve of Heister. It's thick mucosa arranged spirally that will keep the cystic duct always open. So cystic duct has to be always open. It's why? Because it's a two-way duct. Bile will come from here, goes down, and bile, if this is closed here, bile will go from here, goes up into the gallbladder. So the spiral valve of Heister, which is basically the spiral arrangement of the mucosa in the cystic duct that keeps the cystic duct open all the time. Now, this is the gallbladder. It is on the visceral surface of the liver. It sneaks underneath the peritoneum. No peritoneum between the gallbladder and the liver. It covers both, right? And the only part that you see from the gallbladder, if I let the liver go down, the only part that will protrude is the fundus of the gallbladder. Here it will be in touch with the duodenum. Okay, so this is the gallbladder, this is the fundus. It's in touch with the transverse colon, and the body and the rest of the gallbladder is in touch with the duodenum. Okay, that's why if you have a gallbladder is known for forming what? Stones, right? Stones, they might protrude through the wall of the gallbladder into the colon or into the duodenum. Similarly, if you have an ulcer in the anterior wall of the duodenum, it can protrude through the wall of the gallbladder, and you have leakage of the bile into the abdomen. Okay, so stone formation is common, especially in, what is it, 3Fs or 4Fs? Female, 40, fair in color, they are, and fat or obese, you know, the 4Fs that are predisposing factor for stone formation in the gallbladder. But anyways, don't worry about that. So this is the fundus of the gallbladder, the only part of the liver that, of the gallbladder that protrudes below the lower margin of the liver here. And you should be able to locate it. It is located at the intersection of the transpyloric line with the semilunar line, which is the lateral border of the lateral rectus muscle. Okay, they intersect here at the tip of the 9th costal cartilage, where the 9th rib meets the costal margin here. Why it is important to know later on for clinical, years, because that's where you look for the gallbladder. What do? You put your hand on the abdomen here like this, pointing your fingers toward the tip of the 9th costal cartilage, and you ask the patient to breathe. When you breathe in, diaphragm is going to pull the liver down, and the gallbladder will go down with it. So you put your fingers toward this point, and if the bladder is informed, the moment it touches your finger, the patient will scream of pain. It's really painful. It's called Murphy's sign clinically. But for now, know that the tip of the gallbladder or the fundus of the gallbladder is located at the intersection of a transpyloric plane with the lateral rectus or the semilunar line at the tip of the 9th costal cartilage on the right side. So this is the gallbladder, this is the cystic duct, this is the common hepatic duct, right? The cystic duct is about 2 to 3 centimeters and, 2 to 3 millimeters in width. All these structures, the hepatic duct, the hepatic artery, and the portal vein posterior, they are all located in the hepatoduodenal ligament here, which is part of the lesser omentum. So again, as I said, right and left hepatic, they will merge to make a common hepatic, then it is joined by the cystic duct, changes its name, become the choledochus or the common bile duct. This is the common hepatic, this is the common bile duct after it, the joining of the cystic duct. Now, when you do an ultrasound, you're going to see that the cystic duct is about 2 to 3 centimeters, and the diameter is 2 millimeters. Common hepatic is 4 centimeters, diameter is 4 millimeters. Common bile duct 8 centimeters, the diameter is 8 millimeter. Now, if you do an ultrasound for a patient and you will find that the common bile duct is like 16 millimeters or 20 millimeters, that will tell you what? You know, there is an obstruction somewhere, right? And that's why the duct is dilated. Okay, so common hepatic 4x4, cystic 2x2, and the common bile duct 8x8, 8 centimeters, 8 millimeters in diameter. Now, as you see, the common bile duct has 3 parts, one above the duodenum, this is the duodenum, and one behind the duodenum, and one below the duodenum before it joins the second part of the duodenum. It's like this. This is the common bile duct, one part above the duodenum, one behind the duodenum, and one below the duodenum within the pancreas, where then later it joins or it opens into the second part of the duodenum. Now, this is the supraduodenal part, and you can see it in the hepatoduodenal ligament together with the hepatic artery. What is this in blue? The portal vein. When it goes behind the duodenum, here it is going behind the duodenum. Now it is accompanying this artery. This artery is a very important artery. It's called the gastroduodenal artery. Why it is important? We're going to study it. It's a branch of the common hepatic. Why it is important? Because it is located behind the first part of the duodenum. First part of the duodenum is known for what? You hear a lot about this patient has ulcer. It's either gastric in the stomach or duodenal in the duodenum. And the commonest site of the duodenum is the first part of the duodenum, the posterior wall. So if you have an ulcer that goes through the mucosa, then it erodes through the muscles and opens to the outside, it might erode this artery, the gastroduodenal artery, and the patient will come to you with severe bleeding. Okay? So the common bile duct, or the choledochus, they call it clinically. Now it is accompanying, when it runs behind the first part of the duodenum, it is accompanying the gastroduodenal artery. Then below the duodenum, what is this? This is the pancreas. As we're going to see later on, this is the pancreas. Pancreas, duodenum is like this, like a C shape, 2 arms, and it is hugging the pancreas. So the pancreas, the head of the pancreas is located between the 2 arms of the duodenum. Now, pancreas is what? Gland. What kind of gland? Exocrine and endocrine. What's the difference? Exocrine needs a duct. It secretes the, digestive enzymes, and they need to go to the intestine, so they need a duct. While the endocrine part, islets of Langerhans, they secrete hormones, insulin and glucagon. They don't need ducts. They go to the blood circulation directly, right? So the exocrine part needs a duct. This is the common pancreatic duct. Now, common pancreatic duct will join the common bile duct, and they form the ampulla of Vater, hepato-pancreatic ampulla of Vater. They become a single duct. It will enters into the second part of the duodenum. And before they enter, they are wrapped by a sphincter. It's called the sphincter of Oddi. So the common pancreatic duct with the common bile duct, they unite, they form the hepato-pancreatic ampulla of Vater, and it goes into the second part of the duodenum. We're going to discuss this again in the second lecture when we discuss the pancreas. So the common bile duct will join the pancreatic duct. They will be forming a common duct, ampulla dilates of Vater, the guy who discovered it, and will be surrounded by a sphincter. We call that sphincter of Oddi. Okay, the 2 ducts. Now, blood supply of the biliary tract, it comes from this hepatic artery, right branch, right hepatic artery, and from the right hepatic artery, we have a small artery called the cystic artery. And of course, we have the right hepatic artery, the posterior superior pancreatic duodenal artery. We'll study that later on. But I want you to remember there is something called, now when you want to remove an organ, the first thing that you do is what? Ligate the blood, the arteries that goes to it. Otherwise, you will have bleeding. So the first thing before we remove the gallbladder, the cholecystectomy, we have to find the artery that goes to the gallbladder and ligate it. It's called the cystic artery. Where do you find this cystic artery? In this triangle. It's called Callot's triangle, border of the liver, cystic duct, and common hepatic duct. Okay? So the first thing that the surgeon will do will go into this triangle, find the cystic artery and ligate it. It's called Callot's triangle, border of the liver, common hepatic, and the cystic duct. You know, if you were to be a surgeon, inshallah, you know, you will find a lot of variation. It's not like what you study always, like a textbook picture. You know, there are variation when it comes to blood supply. There are variation when it comes to ducts. For example, cystic duct, you might find it, you know, very long. You might find it, you know, united with the common hepatic, or very short, or joining the common hepatic on the left, from above, from below. My point of this slide, you know, you have to keep in mind there are variation of how the ducts are formed or joined. Similarly, it's not always that you have two common hepatic ducts. In 20% of us, we have an additional duct. That could be joining the cystic, could be joining the common hepatic, could be joining the common bile, could be more than one, could be joining the gallbladder. Again, the point of this slide, expect to see in 20% of people more ducts, and that can be joining anywhere. Cystic duct, common hepatic, common bile duct, from the right, from the left, more than one duct, and so on. Now, nerve supply, as I said, for all organs, it's going to be autonomic nervous system, sympathetic, parasympathetic. Sympathetic will prepare you for fight and flight, parasympathetic for rest and relax. Origin of sympathetic fibers, where do they come from? Thoracolumbar, meaning from the spinal cord between T1 to L2, thoracolumbar. Parasympathetic will be craniosacral, cranial nerve, or from the sacral segment S2, 3, and 4, right? Now, what do they do? You had a lecture on that. I'm going to leave that to physiologists. But I'm only interested in one thing, and I want you guys to remember this. Pain fibers from the viscera, how do they gain access to the central nervous system? How do they tell your brain and spinal cord that there is pain coming from this organ? They have to have access to your central nervous system. How do they do that? Pain fibers will hitchhike backwards with the autonomic fibers that are coming down. So they will enter the spinal cord into the same segments where the sympathetic fibers are coming from. That's why you have referred pain. I'm going to discuss this in details in my second lecture, tell you the concept of referred pain. Do you remember a day when you said, oh, I have pain in my ureter today? Or I have pain in my gallbladder? Or I have pain in my heart? Do you do that? Never. You might say, I have pain in my shoulder, I have pain in the right upper abdomen, I have pain in my groin, back, thigh, and so on. This is a concept of referred pain. We're going to discuss it later on when we discuss the nerve supply. So to us, all viscera, autonomic, sympathetic, parasympathetic, simple. Physiologist Dr. Peter is going to talk about it, or they spoke about it already. To me, what matters is that nerve fibers will go back and hitchhike. I will enter the spinal segments where these sympathetic fibers are coming from. And accordingly, pain will be felt in that area supplied by those spinal segments. We'll discuss it in the second lecture, inshallah. See you at 2. Peter.